Hi, I'm Jennifer Ramsey. I'm a certified nurse midwife and a Menopause Society certified provider. I'm practicing for a medical conference that I'm presenting at in a couple of days, and I've had several people ask me if they could see my presentation, so I'm recording it today. If you have questions or comments, you're always free to reach out to me either by text or by email. I practice in a midwifery and OBGYN group at mHealth Fairview Riverside in Minneapolis and St. Paul. My main objective is for you to feel comfortable prescribing menopause hormone therapy in just kind of the basic cookie cutter scenarios and then dealing with some of the side effects that pop up. We will end this discussion with female hypoactive sexual desire disorder, covering a little bit with flibanserin and testosterone creep. I have no disclosures, sigh, maybe someday. And this presentation was created totally old school, no AI. I do discuss how I handle things that are beyond the FDA sanctioned list and beyond some of the guidelines, but I will point that out as it occurs. So as far as my references go, I lean pretty heavily on the Menopause Society. They are a fantastic resource, and if you're interested in this area of practice, I would encourage membership to them. When I've used other resources, they are marked on the slide. What used to be NAMS, or the North American Menopause Society, has adopted the name Menopause Society, so those two terms will be used interchangeably. My intent is to use as inclusive language as possible. For the purposes of this presentation, the term woman or women will refer to people assigned female at birth, and most of the data, evidence, and treatment recommendations provided are based on this population. So to start, if someone was born with ovaries and they live long enough, they will experience menopause. And as we were all aware, in the early 2000s, the post-WHI era, everyone stopped prescribing hormones and using hormones. I think the pendulum is swinging back, and there's been more research, and the data from the WHI has been restudied, and everyone, clinicians and patients alike, are becoming more familiar and accepting of the benefits of menopause hormone therapy again. So, what causes menopause? The ovaries run out of eggs, and with that, then they stop producing as much estrogen, progesterone, and testosterone. Every organ of the body has estrogen receptors. The brain, the genitals are particularly rich with estrogen receptors. I do often get out the straw chart with patients, which is the stages of reproductive aging, and it's most relevant for those who are still bleeding. However, I find many people feel very validated to document what their experience is not in their head. It is a real physiologic process, and the changes that are taking place are as dramatic as when somebody hits puberty. But when a young person starts menstruating, there's just more guidance, education, ritual. But when the ovaries start closing up shop, the physiologic changes are as dramatic, but it's kind of crickets. Don't ask, don't tell. And then we are grown, capable, competent women, used to moving through the world with bodies that respond in a certain way. And all of a sudden, our bodies don't do that anymore. So I'm sure you have all seen these definitions before, and I know that you know how to read. So once again, there are estrogen receptors in every organ of the body. So the symptoms are more than just vasomotor symptoms, hot flashes, night sweats, and dry vagina. There is not one menopause symptom or experience. It's really varied depending on the person. So I've structured this presentation so that I will present a case study, then talk about the material, and then come back to it for an audience response. So as part of this, of course, we're not going to have the audience response, but I will still return to the case study and we'll talk about the answers after I've presented material. So first case study. This is Mary. She's a 48-year-old, overall healthy, has noticed changes to her menstruation, but her main complaint is that she just doesn't feel like herself. She is angry all the time. She would like to have her hormones tested to see if she's in perimenopause. So what would you do? So I get so many people who the first thing they want is patients want their hormones tested. And my answer is no. We treat based on symptoms, not on labs. And if you are thinking about labs, these are the ones I would consider. Maybe a TSH to follow up on menstrual changes and concerns. Or if you're trying to diagnose primary ovarian failure, if appropriate, you could draw an FSH and an estradiol. So I usually will go through the hormones in the regular ovulatory cycle, just as part of education, so people know why I don't recommend drawing hormones. So for somebody who is actually ovulating, you can see in the first half of the cycle the estrogen builds and tells the endometrium to grow. Then there's kind of a complex cascade that occurs, which triggers ovulation. Then the second half of the cycle is dominated by progesterone, which tells the estrogen, whoa, hold on, and it stabilizes that endometrium for possible pregnancy. Then if no pregnancy occurs, then both the estrogen and the progesterone drop and it triggers menstruation. This is what happens in the years before menopause. It's total hormonal chaos. You can see the estrogen and progesterone are overall declining, but in that, the ovaries pulse, giving very high to very low levels and making a state of hormonal chaos. So I do want to touch on primary ovarian insufficiency, or POI, which is menopause before age 40. The way we diagnose it is with amenorrhea times 4 months or more and a high FSH and low estradiol on 2 separate occasions at least 4 weeks apart. People with POI are at high risk for many increased risks and usually need to have their hormones supplemented with very few exceptions. If you are not comfortable with this, please, please, please refer them off to an OBGYN or a menopause specialist. And then just one last little point, just food for thought, tuck it in the back of your brain. 1% will return to spontaneous ovulation at some time. And so please never tell anyone they can't get pregnant. So now for why we're all here. Let's talk about menopause hormone therapy, or MHT. These are the FDA approved indications. This is the most narrowly defined group that can benefit from MHT. And finally, after what I would call a travesty for women's health, after the WHI, the FDA removed its black box warning this past year. But what does that mean? So, the main takeaway from the FDA removing the box is that the black box warning was scary for both patients and clinicians, and it was preventing many people who could benefit from prescribing or using menopause hormone therapy. So the FDA has now changed to encouraging a conversation about the risks and benefits, especially when in that golden window of within 10 years of menopause and before age 60. There are 2 ways to take menopause hormone therapy, local and systemic. We're going to hit local first. So local estrogen therapy is used to treat genital urinary syndrome of menopause, or GSM, the vaginal symptoms, but also the urinary symptoms. When used in this way, there is very minimal systemic uptake, so it can be considered in women with a history of breast cancer if you're consulting with their oncologist, and you do not need a progesterone to protect the uterus or to oppose the estrogen. This is not in the guidelines, but there are some vocal menopause experts that talk about local estrogen therapy for everybody over the age of 55, just for genital health maintenance. The American Urologic Association, or the AUA, released a guideline this last year on genital urinary syndrome of menopause. It's open source, so you can go ahead and Google it. The 2 most pertinent statements to our topic are that there is no evidence linking the use of low-dose local estrogen and the development of breast cancer, and that consideration of low-dose estrogen for breast cancer survivors is a viable option when you're consulting and in collaboration with your oncologist. So how do you prescribe low-dose estrogen? There's a vaginal ring called a E-string, there's a vaginal tablet, and vaginal cream. In the cream category, there is an estradiol product, which is bioidentical, and a Premarin, which is conjugated equine estrogen. I like the estradiol better. It's closer to what our bodies make, and I find it is also better covered by insurance. So this is what it looks like. It comes with an applicator. And the first thing I tell people to do is throw away that applicator, because it gets the estrogen into the vagina. And really, the benefit of the cream is being able to apply the cream right to the tissues that need it. So I tell people apply a 1-inch strip to your index finger and apply to labia and vagina, vaginal intritus. Do this every day for 2 weeks and then 2 to 3 times a week. My first preference is often the cream because it gets to exactly the tissues that need it. However, some people find it messy and they prefer the ring or the tablet. In breast cancer survivors, oncology often prefers the more controlled dose routes of the tablet or the ring because it's harder to inadvertently overdose. I've had providers and patients ask if they can use low-dose vaginal estrogen every day. Here's the deal. They will be getting more than what has been studied, and so we do not know how much systemic uptake they will be getting. So ask, are they an okay systemic estrogen candidate? And is their uterus protected with an estrogen, or with a progesterone? Sorry. Here is a list of the non-hormonal treatment options for GSM. Vaginal moisturizers can be really effective. There is data coming out right now about the benefits of hyaluronic acid. Vaginal moisturizer is a lotion for the vagina. And for anyone who spent the last weekend in Minnesota, you know how dry everything is. Well, the vagina needs some love too. Now, on to the big guns. Systemic hormone therapy, menopause hormone therapy. When I've done this talk in the past, I've gone over the WHI in more detail in the post-analysis, but I'm hopeful that I don't have to spend so much time proving that it's safe in many cases and for many people anymore. What came out of the WHI was this healthy cell theory and this golden window concept. If someone has been in an estrogenized state, then they still have the protection of those sex steroids, the protection that's provided for overall health. But once someone has been more than 10 years without their ovarian estrogen, then many of the comorbidities of aging may have already started. So the beginnings of cardiovascular disease, the beginnings of dementia, possibly breast cancer. Then if you add systemic estrogen back to these people, estrogen will make those processes worse. That's why when estrogen is used in the golden window in a fairly freshly estrogenized person, so within 10 years, it is considered protective against many of those things. However, please note, at this time, menopause hormone therapy is not recommended for use as primary prevention, but I do think the pendulum is swinging a little bit. So we've talked about patients that are menopausal. What about patients that are still bleeding, that are perimenopausal? Consider a low-dose oral contraceptive pill or birth control pill. It is estrogen and progesterone tied up into a neat little package, and it's stronger than menopause hormone therapy. So it will control that awful perimenopausal bleeding better and provide contraception. Because remember, even at age 50, the rate of spontaneous pregnancy is 1%, so it is possible. Menopause hormone level hormones are not strong enough to provide contraception. But first, you have to ask yourself, are they a safe birth control candidate? Do they have hypertension? Are they a smoker? Do they have migraine with aura? If so, then no, they're not. But if those things are negative and they're a good combined oral contraceptive candidate and it works well for them, they can actually stay on their pill until the average age of menopause, which is going to be 52 or 54. If the pill or the combined oral contraceptive stops working well for them, and I think of that as kind of breaking through with like vasomotor symptoms or other symptoms of menopause, then that would also be an indication that it's time to switch to menopause level hormones. So let's go back to Mary. I would not draw labs. We already know she is in hormonal chaos, so I would not do A. B, lifestyle is great and certainly a big piece of the puzzle, but sometimes I think that's all these women get, and it's really frustrating as an option. So now, what about starting her on an SSRI? So before I sought out more menopause education, offering an SSRI and a referral to one of the OBGYNs I work with was kind of my go-to. And the SSRIs can work, but hormones will be more effective. And for some, the side effects of SSRIs and SNRIs are not benign either. So often estrogen is going to work better and provide less side effects. So I would do D. I would talk to her about hormones. And I said it this way about hormones because I don't know yet if she wants to go on an OCP or menopause hormones. Because my first option would be to recommend an OCP. But I have many people that are like, yeah, I'm not going back on a pill. My friend has a patch, I want a patch. And so then I can give her a patch and some progesterone, and I talk about the risk of unscheduled bleeding, but also say that we can work with that if that is a problem for her. So our next case study is Kristen. She is a 54-year-old menopausal woman. She's been menopausal for about 2 years with some comorbidities, which are all well managed. She has severe vasomotor symptoms and was started on an SSRI, which didn't help. So she sought care somewhere else and ended up with some compounded hormone pellets injected. Now she's bleeding again and she's scared. So, systemic menopause hormone therapy is the gold standard for the relief of vasomotor symptoms, hot flashes, night sweats. Not only do vasomotor symptoms affect the quality of life, the more someone has and the more severe they are, the more likely they are to have issues with cardiovascular, bone, or brain health. Vasomotor symptoms are not benign. Estrogen provides the most relief, but just so you know, there is a protocol within the Menopause Society that uses 300 milligrams of permetrium at bedtime to help with sleep and decrease vasomotor symptoms also. The other thing to know is that the estrogen in a contraceptive, so a birth control pill, is 4 times more biologically active than menopause level hormones. Menopause level hormones, what we're trying to do is we're just trying to replace a portion of what our ovaries were putting out during the heyday of the childbearing cycling years. So principles of use. Start within 10 years of menopause and before age 60. So kind of that golden window and the healthy cell theory. Do I ever start someone outside of this? Yes, but it's a little more of a nuanced risk-benefit conversation. I like to have a current lipid panel and blood pressure so that I can use a CVD risk calculator as part of our decision making. For someone with a uterus, if they are taking an estrogen, the hormone that tells the uterus to grow a lining, then they need a progesterone to balance or oppose that estrogen. Then after starting them, I usually have them check in about 12 weeks and then annually. There used to be a recommendation for stopping after 5 years, then after 10 years or age 60, and that's really not the case anymore. The recommendation is for shared decision making. What kind of health changes have they had? What are their feelings about it? The one caveat to that is if they are on an oral estrogen at age 60, then the recommendation is to switch to a transdermal. So the absolute contraindications to systemic menopause hormone therapy is going to be unexplained vaginal bleeding, history or presence of breast cancer, DVT history, PE history, active or recent MI, liver dysfunction or disease, or known or suspected pregnancy. Now, I will add a couple of comments just about the breast cancer one and the DVT. Now, recently, in collaboration with specialists in those areas, we have engaged in a risk-benefit discussion with a patient that was seeking menopause hormone therapy. And so, I'm very clear with the patient about the fact that it is listed as an absolute contraindication. And then we talk about their specific ins and outs with it, and with collaboration with their specialists in those areas also. So send them on. This is a very nuanced conversation about risks and benefits and a lot of education with the patient, and I'm more than happy to do that. So I want to hit on transdermal versus an oral estrogen. So when you think about it, transdermal estrogen skips the GI and skips the first pass liver effect or metabolism. And while this has not been studied for this with a randomized controlled trial, all of the observational data upon like meta-analyses have not shown an increase in clotting. So transdermal estrogen is often thought of as much kind of a much safer, lower risk option for menopause hormone therapy. So, when discussing breast cancer risk with menopause hormone therapy, I wanted you to have the numbers. And so, this is directly out of the WHI. Based on that data, they had 3 additional cases per 1,000 females for 5 years of combined use of conjugated estrogen and medroxyprogesterone acetate or MPA use. Medroxyprogesterone acetate is it's an old school progesterone. And now I would say that the current first line progesterone we use is micronized progesterone or prometrium. Prometrium is considered metabolically neutral, and it does not appear to increase the risk of breast cancer or cardiovascular disease. So what about those with BRCA1 or BRCA2 or a CHEK2 gene? So there again, very nuanced conversation and discussion. It's really helpful if they've been to genetic counseling. Well, if they know they have BRCA1, 2, or CHEK2 gene, they have been. And then those genetic counseling reports are really very helpful when counseling about risk. And this is totally somebody who is not cookie cutter and they need a nuanced discussion, and so send them on. And they may need to be counseled about other risk reducing methods. So prometrium is my first line of a progesterone because it has such great sleep benefits and it's bioidentical, and so it carries less risks than some of the old school progesterones like MPA. MPA is mixed in a peanut oil, so if there is a peanut allergy, then you need to send it to a compounding pharmacy and have it mixed with olive oil instead. Some people feel great on prometrium. Some don't care, they're very neutral, and some really don't tolerate it well. So they have mood symptoms, fluid retention, or bleeding. And so the other thing that I know about prometrium is that it has very large molecules, and so it'll absorb better with food, and it does not work well in a gel, lotion, or cream. What are the main adverse events do people see when starting menopause hormone therapy? I think of the 3 Bs: bleeding, breast tenderness, and bloating, and then also some mood changes. And so when I'm first starting people, I always talk to them about the fact that this is really a work in progress. And as time passes, what works well for a while may change, and we may need to pivot again. It's not a one and done. My standard is usually to do a 0.05 milligram estradiol patch, changed twice weekly, and 100 milligrams of prometrium at bedtime. If someone my charts me with what I think of as a progesterone adverse event, so the problems with the mood or the fluid, that type of thing, or the bleeding, and they're really engaged, I may have them take a 2-week progesterone break and see if the symptoms resolve. Or we could just switch their progesterone and see if that helps. Now, when I'm doing this, I'm very clear and provide a lot of education about the risks of taking an estrogen without a progesterone. And if she does that long term, she's at high risk of uterine cancer. But 2 weeks is not going to give her hyperplasia, and it might be able to help us kind of hone in better on what is going to be a better option for her as far as the progesterone goes. The Menopause Society does have a really nice practice pearl where they outline the different progestogens and what you need for uterine protection. Spotting is by far the most common adverse event. And just if you remember, if it's happening in the first 6 months after initiation or after a dosage or route change, it's considered normal. If it's not happening in that window, if it's persisting beyond that, then they need an endometrial workup with a pelvic ultrasound and an endometrial biopsy. So spotting and unscheduled bleeding is more common the closer someone is to menopause or if they're perimenopausal. The big thing about starting a perimenopausal woman on menopause hormone level therapy is that you're going to mess up their cycle. And so for these, you can consider cyclic progesterone or Mirena in the first 5 years. Also, Netta or Agestin or Slind is a nice option too. If someone is perimenopausal, using Slind or the or progestin only in the dosage for as a progestin only pill which is 4 milligrams a day, it not only protects the uterus, but it serves as as contraception. And what I mean by cycling the progesterone, let's see, I think I might have that in the next. No. So what I mean by that is have them take the estrogen the entire time, but use the progesterone for 14 days on and then 14 days off. If it is, or sometimes I'll even have them use the progesterone for 21 days on and 7 days off, which mimics a birth control pill a little bit better. And extra, a little bit of more days using the progesterone is not going to be harmful. So now here is, I thought it was helpful to have the standard equivalent estrogen doses of various routes. So the one that I use probably the most, or transferring back and forth, is if somebody's on an oral estradiol, so 1 milligram is the standard dose, and I'm switching them over to a patch, then the equivalent dosage is going to be 0.05 milligrams. Unless there is a reason not to, I always opt for the transdermal. I like the one that's twice a week. It's slightly smaller and better tolerated. You can place it on the abdomen, hip, low back, shoulder, not the breasts. I tell people to alternate sides. If the skin gets irritated, then move to a different area of the body entirely. The adhesive residue can be removed with baby oil or mineral oil. And just like any transdermal patches, you can shower, swim, sauna, etc. For the progesterone, I usually start with permetrium anywhere from 100 to 300 milligrams. I have patients play with it. I usually have them start at 100 for a week or so, and then if they want to try 200 to see if it helps with their sleep, do that. But now here's the kind of the take-home thing, is that if somebody is using continuous use progesterone, then it needs to be 100 milligrams daily. If you're cycling it, then the progesterone needs to be at least 200 milligrams daily. I really don't use combined products very often. Mostly if someone has a request or comes to me and they're already on something that's working well for them, then I'm fine to do that. But they're often more expensive and there's less choices in being able to tweak the dose of estrogen and the type of progesterone if needed. So this is a fantastic resource, up to date, has a great chart of the available menopause estrogen products. So you've probably heard me throw the word bioidentical around a lot, and it's totally a marketing term, and but patients seem to kind of respond to it very well. And so what I mean by this is that the medications I'm prescribing are the exact same chemical compound that is made in the ovary. So I think of bioidentical as having two classes, FDA approved and compounded. So compounded hormones are not safer. There's less regulation and there's less safety data to them. And while shared decision making and patient preference is important, most of the people that are putting out our guidelines say that it should not be used as the sole reason for using a compounded product if there is an equivalent FDA product available. So we're going to come back to Kristen. I have several summary points that I want to address here. First, I know that she has many comorbidities, and she would absolutely not be a safe combined oral contraceptive candidate, even if she were still menstruating. But with the menopausal level hormones, you can always ask yourself, are any of these something I would recommend castration for? Because the menopause level hormones are just replacing a fraction of what the ovaries were putting out. Her comorbidities are well managed and her CVD risk calculator is low, so in my mind she is a transdermal estrogen candidate. I would think twice about using an oral, and I maybe wouldn't with her, just because of the comorbidities. So now, what about the compounded pellets? We have absolutely no idea of how much of each of the hormones she got and so we have no idea what her uterine lining looks like, if she has hyperplasia, endometrial cancer. So I would order a GYN ultrasound. If the lining is thick, or if the lining is thin, 4 millimeters or less, I would consider starting her on a menopause hormone therapy. But also, This is not cookie cutter, and so it's totally fine to order the ultrasound and then send her to an OBGYN or menopause specialist for possibly an endometrial biopsy and a further discussion. All right, what do you do with patients who have had a history of cancer? I thought these figures out of the Lancet, for reference, are helpful that talk about the different types of cancer history that would kind of give you pause before you prescribe any menopause hormone therapy. And then the other thing is I always, you know, reach out to, I'm not afraid to reach out to their oncology team either, and have found usually the oncologists to be very responsive. And so now what about breast cancer? It's still listed as an absolute contraindication to systemic menopause hormone therapy. However, the conversation is becoming nuanced, so it's worthwhile to send them on for further discussion with an expert. It is helpful if they're involved with a cancer survivorship program. I have personal experience working with the people at the U, and I know that the Mayo has a great program, and that they have current within the last 5 years of genetic testing, and then hopefully they can get someone that will have a discussion with them about their unique circumstances. So, for people who don't want to or can't use hormonal therapy, non-hormonal therapies, the Menopause Society has a great patient education handout about the evidence-based reviews. And so these are therapies that have stood up in randomized controlled trials as providing relief from vasomotor symptoms. I wanted you to have a list of the meds and the dosing supported by the Menopause Society for relief of vasomotor symptoms. And then here's the list and dosing of the various SSRIs and SNRIs. So, but what about the new neurokinin receptor antagonists, fezolinetant and elzanatant? I'm sure we all love to revisit the old HPO axis, hypothalamus, pituitary, and ovary feedback loops. So, if someone who is ovulating, the hypothalamus releases gonadotropic releasing hormone, or GnRH for short, that tells the anterior pituitary to release FSH and LH, which tells the ovary to ovulate. FS and LH and increased levels of estrogen feed back into the pituitary and tell it to stop, and they feed back in the estrogen in particular feeds back into the hypothalamus and tells that to settle down and quit releasing GnRH. Well, during menopause, we lose our levels of estrogen, and so we lose this part of the feedback system. Then, and I thought this was fascinating, but the GnRH pulse generator sits right next to the body's thermoregulatory center, and they found that each time GnRH pulse generator fires, it triggers a hot flash. And so these new meds work on the neurotransmitters that come before the GnRH pulse generator in the hypothalamus. Say that 5 times fast. These are called the candy neurotransmitters, and it blocks them. So it reduces the number of times the pulse generator fires, thereby reducing the number of hot flashes. So really pretty exciting. And this is the prescribing information, and it's first in class, so you can be pretty guaranteed that it's going to need a prior authorization. It is FDA approved, and it's been shown to reduce vasomotor symptoms as well as estrogen. In the trials, they did see a 2.3% of women receiving Veozah or fezolinetant, and 0.9% of women receiving placebo saw increases in their LFTs. After stopping the medication, their LFTs returned to normal, and those that did have a spike reported multiple symptoms of really not feeling well. So it's not like a hidden phenomenon. But that did cause the FDA to recommend monitoring of the LFTs at baseline, 1 month, 2 months, 3, 6, and 9 months. Now, elinzanetant was the next drug in this class, released just at the end of last year, and it's thought to be more effective because it blocks 2 different types of neurokinin receptors. The main adverse event was fatigue, dizziness, seen in 11.9% of patients compared with 3.5% of people taking placebo. There's thought to be less liver involvement, but it still is recommended, but we still recommend drawing a baseline LFTs and then 3 months after starting. So we're coming into the home stretch. Shalonda is a 48-year-old perimenopausal woman with a history of migraine with aura, and she complains of perimenopause symptoms, including low libido. And she wants her hormones and she wants testosterone cream. So let's talk about female hypoactive sexual desire disorder. First, do women really care about sex? And the answer is yes. Sex helps just in its own right, but then also sex helps maintain relationships, and sexual well-being is strongly related and correlated to overall health and wellness, a feeling of health and wellness. So flubacerin, or Addy, works for about half of the people, and for those, it has shown to help people have 1 to 2 more satisfying sexual events per month. So you can decide if that's something that is worth it. Each person decides if it's worth it to them or not. Take it every night before you go to bed. The one thing is if you're going to have or have had a heavy night of drinking, skip it that night because it can cause you to be really pretty dizzy and even have some syncope. So there's a lot of buzz around testosterone use for women, and sometimes people come to me thinking that testosterone is going to cure everything, libido, energy, well-being. And I worry a little bit that it's being sold as the modern snake oil on TikTok and Instagram. There is a global open source guideline about how to use and prescribe it that you can Google, and many of the big hitters in the world of women's health across the globe participated in writing this guideline. So the Menopause Society has a practice pearl that lays it out really pretty nicely. And so 5 milligrams of gel, which is 1/10 of the dose given to men daily, and then rubbed into a place with hair. And the reason you want to do that is it can cause hair growth in that area. And so if it's somewhere that you're already dealing with hair, then it's not a big deal. So don't rub it on your face. Contraindications are liver disease and hyperlipidemia. So to start, I get a baseline LFT and lipid panel just to make sure that we don't have those things going on. And then I get a testosterone and a sex hormone binding globulin. I redraw the testosterone once a month until we have a stable level. The goal is to hit the premenopausal physiologic range. So how do you order it? In this case, I do use a compounding pharmacy because there is no product made for women in the US. At first, my clinic, we were using the product Testim, which is made for men, and telling people to use just 1/10 of the packet or little tube, which is fairly sloppy dosing. And we had several people come back with supraphysiologic levels. And so you want to let the pharmacist know that you're looking for 1% cream, or so that 1 gram of cream contains 10 milligrams of testosterone in an HRT base. I usually have them dispense it in 45 grams, should be a 90-day supply. And the dose is 1/2 gram, and it's usually dispensed like in a click or a pump container. So testosterone is a controlled substance, so you'll get an Improbata screen to sign it off, and you won't be able to automatically put in refills. You have to redo it. So that does help in making sure that you're keeping up on people's monitoring of their testosterone levels. This is what my actual Epic order field looks like and what I enter where. So 45 grams, and no refills. Apply 1/2 gram or 5 milligrams of testosterone to the back of the calf, outer thigh, or buttock, and then the notes to the pharmacy. All right, back to our final case study, Shalonda. So for I really don't like to make too many changes at once. So typically I'll start the estrogen and progesterone first and then have them come back in 12 weeks for a med check. And then we can talk about the testosterone and getting the labs for that. Or sometimes I'll talk about getting the labs right away so it's ready to go. Um, B, she is perimenopausal, but she gets migraine with aura. So she is not a combined oral contraceptive candidate. So our next option is going to be menopause level hormones, but we'll have to discuss the risk of unscheduled bleeding and messing up her cycle. And the other piece of this is that menopause level hormones are not going to provide contraception. And so we need to think about that if she's having intercourse with a sperm producing partner. It's going to be C, it's going to be hard to get Veoza covered for her, and it may not help with the body and joint aches as well as the estrogen would. And so I would start with a transdermal standard dose estrogen patch, and then probably a cyclic progesterone because she is still cycling, and so 200 milligrams, and then do it either 14 or 21 days. Now the thing about doing a transdermal estrogen is it has less risk of increasing your sex hormone binding globulin and further driving libido down. And so when compared with oral, so I do like to use a transdermal, especially for people that are have a complaint of low libido. So I do have patient education that I use and have shared with everybody. Obviously, those watching the presentation that I'm making today don't have access to the course handout I made for what I'm doing this weekend. But if you're interested in it, you can send me an email and I'll be happy to send a copy of those to you. Or if you have access to the mHealth Fairview Epic system, then you can search me out and borrow those if you would like. So lifestyle is really the key to aging well. And I really do think that it becomes a bigger and bigger piece of the puzzle. And I try to emphasize to people, particular or women in menopause, that they need to do weight-bearing exercise and weight training. Otherwise, they lose it. And so that becomes more and more key to living a healthy life. My take-home notes are going to be that if a person is born as female and lives long enough, they'll experience menopause. Some people may transition without any issue. Others may be really severely affected by the change. Systemic estrogen replacement is the gold standard for treatment of night sweats and hot flashes. Local estrogen is the gold standard for vaginal complaints. The safest systemic estrogen replacement is going to be a transdermal route. And if there's a uterus there, then you need to protect it with some progesterone. Hormone therapy initiation within 10 years of menopause or under the age of 60, kind of during that golden window. And when used in this time frame, menopause hormone therapy is protective of heart, bones, brain health, and decreasing all-cause mortality. If you're interested in this type of practice, then consider membership to the Menopause Society. Like I said, they have phenomenal education for patient and for providers and clinicians. And then as a sideline, I would also recommend reading the Menopause Society position statement from 2022 on hormone therapy replacement. It's a fairly easy read. It's about 10 pages and it has a lot of key points and summaries involved in it. If anybody has trouble accessing this, please send me an email and I'd be very happy to send it out to you. So thank you so much for your time and attention. I hope this has been helpful. And like I said, if you've got any questions or any comments, I'm very open to all of that. And please reach out. Have a good day.